Thank you. Ladies and gentlemen, you've already now been exposed to what are the kind of abnormalities you see in the retina on an OCT. Now, let's now discuss their significance. This is my disclaimer. Now, the fact is that OCT is the bedrock on which the management of retinal disorders is anchored, both in terms of their diagnosis and in terms of their follow-up. The abnormalities that we will see, they can be used for diagnosis, for treatment, for follow-up, and for prognostication. So let's start with some of the basic abnormalities. First, we discuss OCT in AMD. This could be dry or exudative, and the dry form could be drusen or geographic atrophy, and then you have the exudative type. So what you see over here, you see the undulation of the RPE. This is basically due to drusen. This is not a wet AMD, nothing needs to be done. But within the wet AMD, you have a situation where you now see that the IS-OS junction has got disrupted. There is a subsidence of the outer plexiform layer and the inner nuclear layer, as well as the outer nuclear layer here. And this is a nascent geographic atrophy. So the geographic atrophy is now setting in. It's still dry, but it is likely to cause vision loss in this situation if the fovea is involved. Then you come to the exudative forms of AMD. This is type 1, where the fluid is basically under the RPE. You have an RPED, and then and in addition to that, you also have subretinal fluid, and you could have intraretinal fluid also. Then you have type 2 CNVMs, where the main lesion is above the RPE. It's amorphous looking, especially you see this part is quite active, and this needs to be treated, but the prognosis is different in the two types of lesions. And finally, you have type 3, what we call RAP lesions, retinal angiomatous proliferation, and there the lesion, the neovascular tissue starts within the retina and then goes down, creates an RPD over here, as you can see, or it may be only in the retina, as you see in this arrow. Can you see this? So this is the early form, that's the later form. Now, OCT can not only help you to diagnose. What you can see here is a type 2 CNVM, but this is a case where post PDT you can see how the lesion disappeared and only hypertrophy of the retinal pigment epithelium was left, which you can see as this darker red line than usual. You can also characterize this pathoanatomy, and you can monitor the effects of your treatment. For example, with the anti-VEGFs that we are talking about, you see SRF with an RPED. With treatment that has gone away, and then the RPED has become much less, but when a recurrence occurred, intraretinal fluid started appearing again. First evidence, even before the vision may get affected. This is another patient where there was a retinal pigment epithelium detachment, very large but sparing the fovea, was followed up till fluid appeared and then was treated, and then this lesion ripped. The RP, you can see there's a discontinuity here. It has ripped. There is fluid, but it still needs to be treated. This is a form of degenerative change of AMD, where you have thinning of the fovea, and you see this cartwheel-like appearance. This is actually not fluid. This is what we call outer retinal tubulation, and this is a sign of severe degenerative change. The other condition where we see OCT changes very commonly are, of course, central serous chorioretinopathy. You can see here there's a neurosensory detachment, and sometimes there may be a small RPE detachment, which will be where it will correspond to the site of a leak on fluorescein angiography. In a chronic CSCR, the added changes that you see is that in addition to the neurosensory detachment, there is this brush border kind of sign, where there's an accumulation of waste products in the photoreceptor outer segments, which you see here. You see it becoming thickened. This is a sign that this is now a chronic form of this disease. And here, the other thing that you see, if you do what is called an enhanced depth imaging, you can see that the choroidal thickness has increased. So the presence of choroidal thickness virtually confirms with you that when you have this with a neurosensory detachment, that you're dealing with a CSR and not with an AMD lesion. This looks deceptively like a CSR, but if you see, you'll see this layer is going up like a dome. On the other side, and this is in the horizontal meridian, in the vertical meridian. It is very important to have this along with you. And here you see that's not there. So this is a dome-shaped maculopathy. Unless you do it in both the meridians, you will miss out the diagnosis. And this, unfortunately, we do not have any treatment, but is usually not a progressive disease. Dr. Gale talked to you about polypoidal choroidal vasculopathy. The importance is, even clinically, you can recognize that it has more of exudation, sometimes a lot of hemorrhage. But when you do the OCT, you'll see this irregular, shallow RPD with a double layer sign. There's another layer under this, which is actually the branching vascular network. So, in addition to that, you also see these very peaked PEDs. This looks like a tomahawk sign. So, it's actually called a tomographic notch sign. It's a sharply elevated PED, fluid, this double layer sign. These are all signs that now you're talking about a PCV. You can actually diagnose based on OCT alone. So, what all will you see? A sharp peaked PED, like you see over here. Sharp peaked PED. Double layer sign I've already shown you within this. Thick choroid with dilated Haller vessels and a fluid compartment, which you see over here. And then you can sometimes actually see a multilobular PD, like McDonald's, like you see over here. And then you can see also a sub-RP ring-like structure. Look carefully at this. This is where the polyp is. It has a small area which is hypofluorescent, hyporeflective, and around that is a hyperreflective area. But be careful not to be confused by another lesion called adult Whittley-form degeneration, which can give you the same kind of picture of a type 2 CNVM. On fluorescein angiography also you can get fooled because it shows hyperfluorescence, but it doesn't show a blurred hyperfluorescence, shows well-defined margin of hyperfluorescence. So that also gives you a clue. But the best diagnosis comes from the autofluorescence, where you see this area where you had this lesion was hyperfluorescent. So the hyperfluorescent on autofluorescence with this kind of lesion and of hyperfluorescence on angiography, which does not increase over time, tells you you're dealing with adult Whittley-form degeneration that does not need treatment. The other important condition is a juxtafoveal telangiectasia, often seen in older women around 50 and more. And here you see what are degenerative cysts. It can also have areas of outer nuclear atrophy, like I showed you. And on fluorescein angiography, it presents like a late leakage from an unknown source. But this is the difference. You look at the area of the RPE, it's absolutely okay. There is no lesion there. However, these lesions can sometimes develop CNVMs. So when that happens, differences will come and you have to pick that up. Now there's another potpourri of disorders. The ERM, which you can see over here, separated from the retina, causes a blunting of the foveal contour, may require treatment by surgery. Macular hole, is it going to do well? If you look at this and if you see the ratio of these two side walls to the base, and if that is more than 0.9, there's a very, very high chance that the hole will close. If it is less than 0.5, the closure rate goes down significantly. So you can actually predict what is the closure rate based on your OCT. The important thing for cataract surgeons, you have a patient who was improving and suddenly now deteriorated 2 weeks, 3 weeks after a cataract surgery. Look at the OCT, you find CME. All you need to do is start the patient on NSAIDs and steroids for some time, and the patient will do wah-wah for you all the time. You're a miraculous doctor. The other important condition you need to understand is arterial and venous ischemia. Arterial ischemia is in CRAO, you have inner layer ischemia, and then you can have venous blocks also causing either exudative or ischemic changes. So let's look at this. This is a central retinal artery occlusion, and this patient, you see when the acute phase occurs, the inner layers are completely opacified, and you can easily confirm your diagnosis. With time, this becomes less and finally goes away, but it will lead to thinning of the retina in that quadrant. On the other hand, this is a central venous, central retinal vein occlusion, venous stasis retinopathy, and this will present with edema, and this edema will be in the central macular area. If you do a radial scan, it's there all over. Now, the other important thing that you have is a BRVO. In a BRVO, on the other hand, if you do a radial scan, you'll find edema in one half, not in the other half. You can actually make a diagnosis based on OCT alone that you're dealing with a BRVO. So you have these cystic spaces, you have subretinal fluid all in one side in BRVO, entire retina in the macula, in CRVO. In diabetic macular edema, it can help you with diagnosis, treatment, follow-up, and prognostication. The lesions which we have are drilled, subretinal fluid, intraretinal cystic changes and all. Let's see. Now, cystic spaces can be small, large, or very large. Large cysts are associated with poor visual prognosis because of effect on the photoreceptors. So this is the important thing, but all cysts respond to treatment. Large cysts may respond a little more slowly. Hyperreflective signals within a cyst are associated with severe disruption of the blood retinal barrier. Now you see here, large cysts treated with one intravitreal injection, another one, did not become okay, and then was given Ozurdex and finally responded. Neurosensory detachment is another sign of diabetic macular edema, present in up to 15 to 30% of cases, more associated with nephropathy, hypertension, and once they become okay, it becomes better. These patients show a better visual prognosis. It's basically because they don't damage the retina as much as intraretinal cysts do. So you can use the OCT as you see here for following how the patient is doing. He's improving, improving further. The other important thing is drill. Drill is a situation where you have a disruption of these layers. You see the ganglion cell layer, inner plexiform layer, inner nuclear layer, they're all now looking as one mass. This means that this patient has a poorer prognosis if this is in the central 1000 micron of the macula. If more than 50% of this gets involved, the visual prognosis is worse, and this is a good prognostic marker. But see over here, this was a patient with no drill. He developed edema, and it looks as if he's developed drill. Edema went off, the drill reversed. What did it mean? Basically, what is happening is edema caused, those cysts caused a crowding of the retinal structures, made it look as if it was amorphous. The crowding went away and it came back. So you talk about drill only when there are no cystic spaces. If there are cystic spaces, it's not drill. Then you have to first wait for that to resolve. So we know that patients with subretinal fluid do better, patients with absence of HRF, hyperreflective foci, do better, and most importantly, patients with an integrity of the ISOS junction do better. Now, if the patient has a lot of hyperreflective spots, the basic thing is, if there are very large in number, the chances are these patients will have early recurrence after treatment. It's not that they don't respond to one treatment or the other. Both subretinal fluid and hyperreflective spots will respond to both anti-VEGF agents and steroids. I've shown you here, this patient had an intact ISOS junction, this one didn't. This one had a good prognosis, this one did not. Now just completing, this is the last part just to show you, this is the map of the macula. Shows there is leak over here, even though, so you know this, if you have to laser, this is the area that needs laser. If it was the entire central area, it will not respond to treatment. These bridging retinal processes are a good prognostic sign. These are bridging processes. It means still communication is there between the inner and the outer layer. So ladies and gentlemen, you can see there are lots of things to be discussed. You can ask whatever questions you want, but it's quite obvious to you that this is a workhorse for us for managing, diagnosing retinal disorders. It's non-invasive, it's sensitive, provides a detailed insight into the pathoanatomic changes, and has revolutionized the management of retinal diseases. Thank you.